Welcome to our first video on joint pain. Let's begin. In this lecture, we will discuss cervical radiculopathy and cervical myelopathy. For each condition, we'll discuss the definition, etiology, clinical presentation, diagnosis, and management. Let's start with cervical radiculopathy. Cervical radiculopathy represents neurologic deficits in the upper extremity due to spinal nerve compression in the intervertebral foramen. Cervical radiculopathy is most commonly caused by either intervertebral disc herniation or spondylosis with narrowing of the intervertebral foramen. Disc herniation usually occurs in the posterolateral direction. Since the intervertebral foramen is located posterolateral to the vertebral body, the herniated disc can compress the spinal nerve root. Additionally, spondylosis, also known as degenerative disc disease, can narrow the intervertebral foramen and compress the spinal nerve root. Here you see the illustration showing two main causes of cervical radiculopathy. As you can see, the herniated disc may compress the spinal nerve. On the other hand, narrowing of the intervertebral foramen by osteophytes in the context of degenerative spine disease will also compress the spinal nerve. In this image, the illustration is showing narrowing of the intervertebral foramen by the herniated disc, but the same area can be affected by an osteophyte and cause similar symptoms. The clinical features of the cervical radiculopathy depend on the compressed spinal nerve root. C5 nerve root compression results in pain in the shoulder and lateral arm. This is because C5 fibers innervate the skin over these areas. The patient with C5 radiculopathy will also have weakness of the deltoid and biceps brachii muscles. This is because the axillary and the musculocutaneous nerves innervating the deltoid and biceps brachii muscle contain C5 fibers. Finally, the biceps reflex will be diminished due to the same mechanism that we have already described. C6 nerve root compression will manifest with pain in the thumb and index finger because C6 fibers innervate the skin over those two fingers. Additionally, the brachioradialis and wrist extensor muscles will be weakened because C6 fibers in the musculocutaneous and radial nerves innervate these muscles. The brachioradialis reflex will be diminished due to the same mechanism. C7 root compression results in pain in the middle finger because C7 fibers innervate the skin over this finger. Patients with C7 radiculopathy will exhibit the weakness of the triceps and the wrist flexor muscles because the radial and medial nerves both contain C7 fibers. The triceps reflex will also be diminished. C8 nerve root compression results in pain in the medial forearm, ring finger, and little finger. This is because the C8 fibers innervate the skin over these areas. Additionally, the patient with C8 radiculopathy may also have weakness of the finger flexor muscles because these muscles are mostly innervated by C8 fibers in the median nerve. Importantly, the reflexes will remain normal because C8 fibers do not mediate any significant reflex of the upper extremity. Here you see the dermatomal map of the upper extremity. Pause the video and take a moment to consider this illustration to help you review the symptoms that were just discussed in the relationship to nerve root compression. A 31-year-old male bodybuilder comes to the physician reporting neck and left arm pain. Physical exam reveals diminished sensation on the left thumb and index finger, along with weakness of the brachioradialis and wrist extensor muscles. Brachioradialis reflex is diminished. MRI shows disc herniation and nerve root compression. Which spinal nerve root is most likely compressed in this patient? The patient presents with neck and left arm pain. The physical exam reveals diminished sensation on the left thumb and index finger, along with weakness of the brachioradialis and wrist extensor muscles. Brachioradialis reflex is diminished. These are signs and symptoms of C6 spinal nerve root compression. So the C6 nerve root is most likely compressed in this patient. Diagnosis of cervical radiculopathy can be suspected based on the patient's history. Weakness and sensory disturbances in the area of the specific nerve distribution may indicate the possible nerve involved in the disease. A thorough neurologic exam of the upper extremity can confirm the patient's neurologic complaints. Finally, the confirmatory test for cervical radiculopathy is a cervical spine MRI. An MRI will show the exact cause of the cervical radiculopathy. Here you see a cervical spine MRI showing cervical radiculopathy. You can appreciate the herniated intervertebral disc, which compresses the spinal nerve root. In this image, one can see a CT scan showing compression of the spinal roots due to osteophytes. Here, one can see the osteophyte at the level of C6 and C7. Take a look here in the axial plane, where one can see how the area where the spinal root exits the spinal cord is more narrow than the opposite side. Management of cervical radiculopathy involves pain control with acetaminophen or NSAIDs. Additionally, stretching exercises may help to regain muscle strength and alleviate the symptoms. Finally, severe cervical radiculopathy due to disc herniation is treated with surgery. Let's move on to cervical myelopathy. Here's our overview slide of the topics we're going to discuss for cervical myelopathy. Cervical myelopathy represents neurologic deficits in the upper and lower extremities due to cervical spinal cord compression. This is in contrast to cervical radiculopathy, which presents with neurologic deficits in the upper extremity and caused by spinal nerve root compression. Let's talk about the etiologies of cervical myelopathy. Anything that can narrow the vertebral canal can potentially cause cervical spinal cord compression. One of the most common causes of cervical myelopathy is degenerative spine disease. Osteophytes in degenerative spine disease narrow the vertebral canal and compress the spinal cord. Trauma may also cause cervical myelopathy. Infections like an epidural abscess or a tumor can compress the spinal cord as well. Cervical myelopathy may present with neck pain and stiffness. Hypotonia and hyporeflexia at the level of the lesion is caused by damage to the lower motor neurons in the anterior horn. In contrast, hypertonia and hyporeflexia below the level of the lesion is due to damage to the upper motor neurons in the corticospinal tract. Loss of sensation below the level of the lesion results from damage to the spinothalamic tract and dorsal column system. Here you see an illustration of the cross-section of the cervical spinal cord. You can appreciate the anterior horn's spinothalamic tract and dorsal column system, the damage of which results in specific neurologic dysfunctions in the case of cervical myelopathy. Diagnosis of cervical myelopathy starts with a thorough neurologic exam, which may show all the neurologic deficits that we discussed in the previous slides. The confirmatory test is a cervical spine MRI, which can reveal the exact cause of cervical spinal cord compression. Here's an MRI of the cervical spinal cord. You can see this hyperintense epidural mass compressing the spinal cord. Remember that since this mass is compressing the spinal cord itself, the patient will experience hypotonia and hyporeflexia at the level of the lesion, and hypertonia and hyporeflexia below the level of the lesion. Management of cervical myelopathy focuses on pain control with acetaminophen or NSAIDs. Acute cord compression requires intravenous corticosteroids to decrease spinal cord edema. However, if the compression is secondary to an infectious cause such as an epidural abscess, corticosteroids should be avoided. Neurosurgical consult should be obtained and the emergent surgical decompression should be performed. A 25-year-old woman is brought to the ER after a motor vehicle accident. Physical exam reveals hyporeflexia in the upper extremities, hyperreflexia in the lower extremities, and loss of sensation in the whole body. MRI shows cervical cord compression. The neurosurgeon has been notified. What's the next best step in the management of this patient? The patient presents with neurological deficits after a motor vehicle accident. The physical exam reveals hyporeflexia in the upper extremities, hyperreflexia in the lower extremities, and loss of sensation in the whole body. MRI shows cervical cord compression. Therefore, this patient has the acute cervical myelopathy. The best next step in the management of this patient is IV corticosteroids and emergent surgical decompression of the spinal cord. Here's a table summarizing cervical radiculopathy and cervical myelopathy. Pause the video and take a moment to consider this table. A 26-year-old male bodybuilder comes to the physician due to pain in his right hand for 3 months. His pain and numbness are exacerbated when he lifts weights at the gym. His vital signs include a temperature of 37 degrees Celsius, blood pressure of 110/80, heart rate of 68, and respiratory rate of 14. Physical exam reveals pain and paresthesia along the medial forearm, ring finger, and the little finger of the right hand. Finger flexion is weakened in the right hand. Biceps and brachioradialis reflexes are normal. Which of the following is the best next step in the diagnosis of this patient's condition? A. Spinal CT, B. Spinal X-ray, C. Spinal MRI, or D. Spinal PET scan. This patient presents with pain in his right hand for 3 months. His pain and numbness exacerbate when he lifts weights at the gym. The physical exam reveals pain and paresthesia along the medial forearm, ring finger, and little finger. Finger flexion is weakened in the right hand. However, the biceps and brachioradialis reflexes are normal. All these findings are consistent with the diagnosis of C8 cervical radiculopathy, that is, C8 spinal nerve compression. The best next step in the diagnosis of radiculopathy is the spinal MRI. Therefore, the correct answer is option C. Here's a slide reminding us of the diagnosis of cervical radiculopathy. Let's discuss why other options are incorrect. Option A, spinal CT, and option B, spinal X-ray, are not sensitive enough for the diagnosis of spinal nerve root compression. Option D, spinal PET scan, is not indicated in the workup of cervical radiculopathy. And that concludes our lecture on cervical radiculopathy and myelopathy.